Hey, good afternoon, everyone. We're very pleased to be here to share kind of some updates on what's happening with implementation of mental health services across California in a very different way than we've been doing it in the past. So just quickly, California Institute for Behavioral Health is a nonprofit that's dedicated to improving the lives of people with mental health and substance use challenges. And we operate under contracts with a lot of different entities, particularly the state. I was asked to share a little bit about the triple aim because that is a big focus for us, for each of the organizations that are here on the panel, and for the State Department of Healthcare Services. So the triple aim is a framework that was created to think about how we provide healthcare services by the Institute for Healthcare Improvement. And it consists of three things, not surprisingly, since it's called the triple aim. The first is improving the patient experience of care. So that means both quality and satisfaction, that they're getting both when they receive services. Improving the health of the population itself, and then importantly, of course, trying to either reduce or at least constrain the cost of healthcare reform. So we are all very much focused on that particular triple aim. And I wanted, since I have a moment, I'm going to do a little plug. We are doing an international conference on stigma next week in San Francisco, and I would invite any of you to come to that. We have about 20 countries coming all around the world, and people from all across the United States. It'll be a very large conference, and we're focusing on what does the research tell us about how we reduce stigma, what do we do in policy, and what do we do in practice. And for those of you, I know you're all very interested in policy, we'll have a panel which I think will be really interesting with about 6 different countries presenting what their particular country has done in terms of policy to try to reduce stigma. So if anybody's interested, you just need to give me your card and I'll make sure you get all the information. But it's next week, so not a lot of time. So let me just frame a little bit of the discussion we're going to have both with Sarah from DHCS and from our panel members. About 6 or 7 years ago, the federal government passed what we call in this field a parity law, which simply means that mental health and substance use services need to be provided in the same way and at the same cost as all other healthcare services. Well, we in California have been a little late coming to that, but we're there now. And one of the 10 essential benefits in the Accountable Care Act includes mental health and substance use disorders. So that means we have to be providing it across the state. And California has kind of leaped into a new way of doing business. In the past, it was all the county's mental health plans that provided all the services with their various providers that they have in each county. But now the health plans are also responsible. So the health plans, the managed health care plans, are responsible for addressing services for people who have mild to moderate mental health conditions. And the county mental health plan is responsible for serious to severe. It's been a complicated process to try to figure that out because I think we're really talking about levels of care. However, we're working very hard at it, and every county and every mental health plan now has a memorandum of understanding between them, kind of addressing how do we do this work together? How do we assure quality together? How do we create team-based care if that's what's needed? How do we do this screening? How do we do the assessment? How do we do the referrals back and forth? And how do we know for sure that referral worked? And the memorandum of understanding, believe me, is much more complicated than that, but at least that gives you kind of an overall understanding of what the MOU has to address. So these are new relationships, very new. I mean, the health plans and the county behavioral health plan have not had relationships in the past. So it's been an interesting process as we've gotten to know each other better and found ways to work together. So we're going to start out, and I'm going to read you some of their bios because I found this, I always find it fascinating reading people's bios. I think I know someone, and then I learn something about them I never knew. So Sarah Brooks is with the State Department of Healthcare Services. She's the Chief of Managed Care Quality and Monitoring Division. She has a great presentation she's going to share with us And just a couple things about her background that you should know. Sarah has an MSW from UC Berkeley, and then somehow managed to go back to Indiana and work for their legislative services agency for about 4 years, and then back to California again. She was the Assistant Director of Policy for the California Association of Public Hospitals and Health Systems, and she's going to give us an overview of what DHCS is doing in this area, and importantly, I think, some of the data that they are collecting. And after you finish, I'll introduce the panelists. Okay, go. Turning it to you, Sarah.
Sandra. You can hear me? Yes. Okay, great. Good afternoon, everyone. Sarah Brooks with the Department of Healthcare Services. So I'm going to provide a little bit of information today about mental health, as Sandra mentioned. Just real quickly, we'll look at Medi-Cal enrollment, Medi-Cal managed care plan responsibilities for mental health services, network adequacy requirements, mental health data reporting, some utilization data that we'd like to share with you that's really new and hot off the press, and then DHCS guidance. So where are we with the Medi-Cal program? There's been a significant shift, as many of you are likely aware, over about the last 5 years, really transitioning significant numbers of beneficiaries into managed care. These numbers are from September 2014, so you can see at that time we had about 11.6 million beneficiaries in managed care, and we were at about 71% managed care at that time. We now know that we're at about 12 million beneficiaries, and we're continuing to grow, and about 80% managed care, and then a significant piece of that shift has obviously been the ACA expansion. So I'm going to talk about Medi-Cal managed care specifically, but these services are also available in Medi-Cal fee-for-service for beneficiaries, just maybe under a little bit of a different construct. So Senate Bill X1 did require Medi-Cal, or in this context, Medi-Cal managed care plans to start providing mental health services, and Sandra talked a little bit about that mild to moderate component. I want to mention that because I think that there is confusion sometimes around mild to moderate and what does that mean. It's not like there's a list of diagnoses that go with the county specialty mental health plans and another list that go with the managed care plans. It's really about functionality. So, for example, somebody could have, for example, a diagnosis of schizophrenia, but they've been maintaining on their medications and really they're at a functional level that the managed care plan can manage their care, and in that instance they would be covered and care would be coordinated by the managed care plan. That same individual, if they needed kind of a higher level number of services and their functionality was at a different level, would be with the county specialty mental health plan. But just moving back to the services, so January 1, Medi-Cal or Medi-Cal managed care plans did start providing these mild to moderate services, and I would say that they're grouped in 5 different areas. There's individual and group mental health evaluation and treatment, so really psychotherapy, psychological testing when clinically indicated to evaluate a mental health condition, outpatient services for the purposes of monitoring drug therapy, outpatient lab, drug supplies and supplements, and psychiatric consultation. So those are really the services that are covered by the managed care plans when thinking about the context of mental health. Some other things just about mental health services, it changed requirements in terms of authorizations for mental health. No visit limitations, so that's a slight change. And then we also did seek the ability to have marriage and family therapists, so MFTs and interns as approved providers to provide some of these services. So in terms of managed care responsibilities or the plan responsibilities, they're really responsible for continuing to ensure mental health screening of all beneficiaries. So anytime a beneficiary comes in, a managed care plan is responsible for doing what's called an individual health assessment, or an IPHI, and this is kind of a first initial look at the beneficiary to kind of identify where are the areas of needs, what types of services does this individual need, and one kind of component of that is mental health, and so from that kind of initial assessment, if they do identify that there are mental health needs, they would then conduct another assessment tied to mental health. That assessment would allow them to determine if they should refer the beneficiary for further mental health services. And that could mean several things. If they determine that the beneficiary is in the mild category, they probably would directly refer that beneficiary to the mental health provider within the managed care plan for services and further assessment. If they're on the more SED or severe level, they're likely going to send them right to county specialty mental health and refer them to the county for services. If they're in moderate, they may make a determination, and if they're not sure, they would send them through to to the managed care mental health provider for additional services. So managed care plans are responsible, their providers are responsible for referring beneficiaries for services when they're medically necessary and related to mental health or any other services. One thing I want to note is that under the MOUs that Sandra talked about, managed care plans and county specialty mental health plans are required to use one assessment tool. So we really wanted to make sure that in a county, the same assessment tool was being used by both entities, because really that should likely result in the same outcome in terms of assessment and where the beneficiary is in terms of needed services. Obviously, managed care plans are responsible for coordinating care. They're responsible for coordinating with the county specialty mental health plans and other local governmental entities that might include regional centers. But they're responsible for coordinating that mental and physical health care, which includes, but is not limited to, the coordination of all medically necessary, contractually required services. So there are some services that may fall outside of the scope of the managed care plan, and they're not required to provide those services. They're sometimes called carved out services, or perhaps they're just not provided in Medi-Cal. But the managed care plan is responsible for coordinating all that care and ensure that beneficiaries getting referrals to services that are needed outside of their scope. And then, of course, it's important, the partnership with the county specialty mental health plans is very important, so that is also a requirement. So how do we get ready for implementation of this new benefit? There's really kind of a big overhaul of work that we do in terms of looking at our plans. We need to make sure that they have all their policies and procedures in place. We need to make sure that they have networks in place that are adequate to provide timely access to their beneficiaries. We need to make sure that they have MOUs in place so that we can ensure that kind of care coordination across different spectrums is happening. So different components happened as a part of our readiness review process. One piece, we worked with our partners at Department of Managed Healthcare, so DMHC, to really look at and verify the networks in terms of whether or not they were adequate to provide timely access to care. There's a significant number of things that are filed with DMHC or with DHCS if DMHC is not involved. For certain plans, they are not. And so we worked with them to review all those policies and procedures and make sure that they were in compliance with our requirements that are set forth in our contracts, in all plan letters, which are kind of extensions of our contracts, and in federal and state law. As I talked about, DHCS required the plans to submit these deliverables and did take a look at the networks as well. Wanted to note just timely access in terms of readiness. I talk about timely access. What does that mean? In California, for mental health services, for Medi-Cal managed care, there aren't requirements in terms of what we call time and distance. So there's no requirement that the provider has to be within X number of miles or minutes from the beneficiary's residence for mental health. But there are requirements in terms of how long do you have to wait to get into care. And so for our plans, we do require them for 10 business days for a non-urgent referral for mental health services. And so one thing that we have seen over the last year, and you'll see this a little bit in the data when we take a look at it, is that managed care plans really needed to ramp up their networks. And so, day one, everyone wasn't accessing care. It's a constant reevaluation of the network of the managed care plan in terms of how many people are actually accessing services. And so they may have had a lower number of providers in January because not many people were accessing care, but they needed to build that up and ramp that up throughout the year. And so that's been a process that has occurred. And then also wanted to just mention, in particular in rural areas, but just in general, the department is really focusing on the emphasis of telehealth and psychology services is a big piece in telehealth, and so that's one component as well. So data, all right, we'll get into the good stuff. So managed care plans in quarter 2 of 2014, they did start reporting some data, and we'll look at another slide in a minute that talks about encounter data. And encounter data, there's a lag, and that's, so what is encounter data? Encounter data is a claim basically that's submitted to us for a service. So when you go to the doctor's office, everything that happens when you're there, any lab, any test, anything they do is included in that encounter, and that's submitted to us for Medi-Cal purposes, and we do gather that information. But there's a lag on it, and we wanted to have some real-time information and data. So we started having the plans report to us monthly and then quarterly in terms of their experience. And that data included referrals, so referrals within the managed care plan. So how many people were being referred for services for mental health to a managed care mental health provider? but also how many people were being referred out to the county specialty mental health plan as well. So we wanted to track that information. And also coming in, how many people were we getting referred from the counties as well. Continuity of care, there were a very limited number of people receiving services in fee-for-service for mental health prior to January 1. We wanted to make sure that those people didn't lose access to their providers. You know, it's really important, I think, in particular with these types of services, when you've built a relationship, that people are able to continue to receive their services. And so we have what's called continuity of care. And a beneficiary can request to the plan that they are able to continue to receive services from that provider, even if they're not in the plan's network, as long as certain requirements are met. So we had that kind of data reported to us. And then grievances and appeals. We really want to know, kind of what's going on. Grievances and appeals is an indicator of what's happening. Are there issues in terms of access to care? Is there a certain kind of service that's not being provided? It's really kind of a telling story. So we collected that data as well. Future aims, and we're going to look a little bit at some of the encounter data, but we really want to delve into the encounter data, look at what's happening, and start using that data to inform us in terms of restructuring the program, strengthening what we've put in place. And then finally, connecting short DOIL. So mental health reports their data through what's called the short DOIL system. And so we want to start looking at those connections between those beneficiaries that are seeking care on the managed care side and also in the county specialty mental health plan side, so that we can understand kind of what types of services are being accessed, are mental health services being accessed on both sides, are people actually getting referred? So when they're in managed care and they're getting referred for services to the county, do they actually show up for services? And if they don't, why is that? And we need to figure that out. So this is my important disclaimer. Okay, so we're going to take a look at some of the new encounter data. We did pull information for 2014, so we're excited. This is the first time we've pulled encounter data, and really that's because of that lag that I talked about. But it's not complete, so I just want to be clear about that, that the data, if I pull it today, will probably look different because we pulled this data last week, and there'll be some time as we continue to kind of update that information. And here's an example of what I'm talking about. So you can see here in January, there likely was kind of a sort of an uptick in terms of services. People didn't know the services were available. They were starting to get noticed. They were, figuring out how do they access care. So you can see the services were increasing. Then you kind of see a slow drop off. Well, clearly 9 occurrences of services didn't happen in December. This is really about the data and it being submitted to us. So just want to kind of clarify that. So some of the data that we do have, I think, is really interesting. We took a look at the beneficiaries accessing care and managed care by age group, and we grouped them together. What you can see is that the majority of beneficiaries accessing care are in that 0 to 20 age group. So these are generally children or older children. I guess we still call people who are 20 kids, I think. But so generally they're in that 0 to 20 age group at 84%. And then 21 to 64 is at about 14%, and then 65 plus is 2%. So the majority of beneficiaries accessing care, and want to hear from Chris a little bit because his experience has been different, I think, but throughout the state is tied to that. In terms of services that were provided, we took a look and kind of grouped things together. And not surprisingly, because of the age groupings that were actually accessing services, you can see 74% of services reported were for developmental screening. And that kind of makes sense given the age group that we find in terms of accessing care. And then the next level down is 17% at psychotherapy. We do see psychiatric evaluation at 3%, and then interdisciplinary team consultation and assessments at 0. That doesn't mean they didn't have services. You'll see that on the next slide, but just the numbers are really small. This just provides the breakdowns in terms of the types of services provided. So you'll see those groupings again and the claims count, and then unique SINs. So I think the important thing to point here is that we know that approximately a minimum of 860,000 kind of mental health services were provided in in 2014. This isn't an unduplicated number. Somebody could fall into more than one area, so I just want to note that. But I think this is significant, and we're very excited about that. And then just have some breakdowns, and this will be posted on the website because you may not be able to read all of this, but breakdowns by plan. So we have, many of our plans operate in different counties, but we've grouped them by parent plan, and so you'll see, for example, Anthem Blue Cross is in a number of counties, but you'll just see one line item for them. But we show the number of enrollees as of September 2014, the number of procedures, and then the percent of procedures for enrollees. And you'll really see that there's a range from 4% of enrollees all the way up to 27%. So it's a wide range, and again, some of that could have to do with that encounter data reporting, and we just haven't received the encounters for some of the plans, but I think that it's an interesting fact to note. And then just finally wanted to mention, when you're looking for information about our managed care plans and how they're implementing this benefit, we do issue what are called all plan letters. As I mentioned, these are extensions of our contract with guidance to our health plans. So APL 13021 talks about the responsibilities of managed care plans in terms of mental health services, and then APL 13-018 talks about the MOU and the requirements that have to be in that MOU between the managed care plan and the county specialty mental health plan. And soon to come, which I think will be issued in the next few weeks, is a dispute resolution all plan letter. And what that is if the county and the plan, or both plans, can't agree in terms of who's responsible for services, that sets forth a process so that they can take that to the state and we can make a determination about responsibility. So that, I think, is my presentation. So thank you so much.
Well, that was great.
Okay.
Very fascinating. So I have a quick question. Were we looking at primarily the managed care data, not the county data? Yeah.
Yes. So this is yeah.
Because the age would be very different if you looked at the county data.
Yes.
Okay, so I'm going to introduce the panel, and they're going to speak in this order. So the first will be Dr. Chris Esquera. Oh, I did it right. Thank you. Dr. Esquera is a physician, and he also has an MBA. He's currently the interim medical director for the health plan of San Mateo. He is board certified in both psychiatry and healthcare and quality management. And he also serves, at the same time you're doing both, he's also serving as the clinical and administrative director of behavioral health for the health plan of San Mateo. His focus in reading his bio is very focused on integrated services and collaborative relationships. And just kind of his interesting notes, he attended USC for both undergraduate and medical school, got that right. And he got his MBA from the University of Massachusetts. Interesting difference. And then we're going to move from there to Suzanne Tavano. Suzanne is the Director of Mental Health and Substance Use Services for the Marin County Health and Human Services. And interesting thing about Suzanne, which I've known Suzanne for a long time, she is both a licensed public health nurse and a licensed clinical psychologist. You don't find many people with that combination. And she's been in a number of different counties. Previously, she was the Director of Jail Psychiatric Services in San Francisco, the Clinical Director and the COO for CPC Walnut Creek Hospital. Then she was the Mental Health Director for Contra Costa County, and then the Behavioral Health Director for Santa Cruz County. So she's been around the Bay Area quite a bit. And she's also the co-chair for the Medi-Cal Policy Committee for the County Behavioral Health Directors Association of California. So she's got a lot of experience to share with us. And then third, we're going to go to Jody Nerrell. Did I get the last name right? Oh, I'm so glad when I get these names right. She's the Director of Behavioral Health for WellSpace Health Center here in Sacramento. It's the largest FQHC in the Sacramento region. And her job is quite broad. She oversees behavioral health integration in 14 health clinics, which is pretty substantial. And at the same time, she also directly oversees WellSpace 5 behavioral health programs, which include inpatient and residential substance use disorders, suicide prevention, youth violence prevention, health access and supportive housing, and children's mental health. It's a lot of responsibility you carry. And then last but certainly not least, we're going to hear from Brianna Duffy, who's the Vice President of National Client Partnerships for Beacon Health Options. She has 20 years of experience in behavioral and developmental health sciences. Her focus is largely on service enhancement and systems change with both public and private sectors, which I thought was pretty interesting. And then she's also, if we're looking at her past, she's done a number of very interesting things, including implementing home and community-based waivers, designing the model of care for one of the first dual eligible models in the country, and implementing a statewide wraparound program. All very interesting work. Yeah. So we're going to start with Dr. Spera.
So I feel I have to do this every time. We were just joking about this earlier. San Mateo County is a little different. We're a little unique. So after having said that, I can set the stage of what I'm going to be describing. So we at San Mateo County, the health plan, the county, and our various other partners, regional center, local education agency, have had a history of working together for various initiatives and all under the guise of integrating services and really having as seamless of a care experience as possible. And I have to step back a little, and when we talk about healthcare in San Mateo, we really mean everything. We're a little excessive in that way, to the point of how we plan our streets, where cigarettes are sold. It gets into that level when we kind of like to dig our noses in. Vis-a-vis behavioral health, prior to the expansion of mental health services for the mild moderate, there was already work between the health plan and county behavioral health to begin to integrate essentially mental health and primary care services. And we were trying to really demonstrate that when you do that well, not only does the person get better, you're also going to be able to save money, and you're going to actually have really cool programs as a result. So that actually set the stage for us to do what we did and make the decision to, with this expansion, have county behavioral health also take on the mild moderate. And it only made sense because they already had the infrastructure and the machinery, so to speak, to be able to manage this population. What needed to occur on both sides was just an evolution in how we understood things. And so this is where we talk about how do you build these structures, and then the culture change and evolution as a result of doing that. So from the health plan's perspective, we previously did not have any structures around mental health. And in fact, the history was, if anything, any member calls related to any mental health or addiction-related issue, we quickly said, okay, call behavioral health. That's just not ours. We don't do this. Blinders are on. That's it. And then, of course, on the county behavioral health side, if they thought, oh, anything medical, anything physical health, go back to your PCP. Maybe we might need to talk to the plan. So within that framework, we needed to build those relationships, and we also needed to build capabilities on both sides. So on the county behavioral health side, they know specialty mental health and the processes are right there, which is very, very different when you get into the managed care world vis-a-vis mild moderate. So not to get into too many details, but one particular example is that the billing in specialty is all about minutes, whereas the billing in managed care is all about complexity. Those two do not necessarily mix very well, and so therefore there have to be education and an evolution in understanding. So it really affects things like your contracting, your fee schedules, how do you talk to each other about encounter data, things like that. On our side of the health plan, we needed to do better with our care coordination. No longer can we say, mental health issue? We don't have to think about that. That's behavioral health. Our care coordinators now actually have to care about that and now have to access and work closely with our community health partners. So not just in the county, but with the regional center, with our education agency, vis-a-vis autism, for example. So it's the job itself has been broader, and the partnerships that we've had to build are richer as a result. So whereas it may have been historically, we can function in silos and we can stay in our offices and not have to do much of any traveling, these days there are many joint meetings between us, the county, either behavioral health or just the health system in general, and to the place where we're really working to build that structure where not only do we work to integrate that experience as people move between these levels of care, and as we are able to coordinate not just between the various levels of care in behavioral health, but also with primary care, with specialty services, with all of the levels of care in the usual primary care services, but also begin to build a framework for how we share data. So Sarah brought up the issue of short dual data is not necessarily mixed with managed care, mild moderate data. We have laid down the groundwork to be able to have that access. Now it's easy to do the business agreement to be able just to share But what we're working toward is also being able to share short DOIL and addition treatment data. And we're very, very excited about that, to be able to do a much deeper analysis. It was just very thrilling in December, where when we did some analytics work to let's just take a look at all the folks who have visited inpatient settings, emergency rooms for behavioral health reasons. And let's send it over to behavioral health folks. They did not know the top 3 people. It was not on their radar. So that was a care coordination issue for us, and clearly an identification issue for them. And so that leads us to ask even deeper questions, better questions, to be able to say, how do we start to do this outreach? How do we find these folks? How do we go do that? Just for that type of overutilization. On the underutilization side of things, from our perspective, we're promoting these services as much as we can. It is actually in our pay for performance incentive for our primary care providers to do depression and anxiety and alcohol screenings. They get paid to do it, we encourage it, and there is a whole process of, upon identification, what to do, of which one of the referrals is to behavioral health. So given that, it sounds nice and rosy, and we do like it, and I'm very happy to be in this setting. The challenges are continually evolving our various cultures to be able to learn each other's language, to be able to understand when someone in behavioral health says something about claims, they may not necessarily say it in the way that we understand it. So that's really a lot of our meetings and getting to understand each other's systems. It does help that some of us, the folks that work at the health plan, used to work at the county and vice versa. I used to be the deputy medical director for behavioral health and behavioral health, so it really helps. And I think it's more of a struggle now to really make this work well and smoothly. And I think we're getting there. The data to me here is surprising because it skews more towards children and sort of young adults. Ours actually has a more even mix between children and adults. And I think that's because, I'm just going to throw out a theory, primary care, specifically on the pediatric side, has had a historic, robust way of screening for their kids. And in fact, I know our primary care providers in our county system are very, very good at doing these screenings at the times that they're supposed to. Adult primary care, not necessarily so, although that's been promoted more and more lately, and really being able to do that. So whereas I think what's helped for us is really promoting that screening, paying for it, and really going out there and letting our providers know this is available to them. And as a result, we've seen good referral patterns for the adult side.
Thank you. Susan?
Hi, good afternoon, everyone. First, want to say that I think we're all just so happy and thrilled that the new mild to moderate mental health benefits have been implemented. Historically, those of us who have been around for a while, there really was a very big gap, actually a chasm, for people who didn't meet the criteria, Medi-Cal beneficiaries who did not meet the criteria for specialty mental health, and had as the only option the state fee-for-service system, and there were a variety of issues that went on there over the years, but very much appreciated. And I think, today, bear with me, rather than starting out by talking about the Marin experience specifically, I thought I would just sort of step back and do kind of a more global discussion for a little bit, because there's so many acronyms that are thrown out. And I think over the years, even though we're 20 years in the making, there's still common misunderstanding out in the community about what specialty mental health is, et cetera, et cetera. So just wanted to back up a little bit and also say that you have 4 examples that might be spoken about how this is all going. But when you step back and look at it statewide, it's a very complicated picture, a very complicated discussion, and there are many variations. So if you start with the facts that in California there are 58 managed care mental health plans. There's only one model. There are 58 of them, but with one model. On the health plan side, there are seven different models, and there are, 25, 26 different health plans participating in those models. And then, in addition, some health plans actually directly manage the benefits, others contract to another entity to manage the mental health benefits. We have the FQHCs that tend to do it all. There are so many ways to look at what is going on right now. It's a very complicated story, but wanted to put that out there because I think sometimes we miss a lot of nuance when we talk about this because it's gotten so complicated. So if there were 58 counties in the room with all of their health plans, some counties, some county-operated mental health plans interact with one health plan, some 2 health plans. Sacramento, I believe, is 4 health plans. San Diego, I believe, is now 5 health plans. So that is rich territory for a lot of variation. So we're not telling you the full California story at this point. So just wanted to mention that. I think the point of commonality for the managed care plans, MCPs, and the managed mental health plans, the MHPs, we have our roots in the 90s in that the 1915B waivers were approved and implemented at that time, and both the 1915B waiver is the basis of managed Medi-Cal health plans, and 1915B waiver different is the basis for the managed specialty mental health plans in the state. So those are our common roots, and then everything gets pretty different from there out. So just speaking to the mental health plan side, I know that we often lapse into saying the county, and the reason we do that is because all of the specialty mental health plans are operated by the county, but they are in fact managed care plans just as the health care plans are. So just to put that clarification out there. In addition, going back to mental health in particular, the mental health plans, in addition to the 1915B waiver in the 1990s, 2 other very important things occurred. There were 2 state plan amendments. One was for targeted case management, which is important, but I think really the state plan amendment, the SPA, for rehabilitative services is really what formed the basis for what the current system currently is. Under the rehabilitative SPA, a number of major things happened. One is it took identified specialty mental health services, and I think there's still a lot of ongoing confusion about what we do. So the state basically established a list of diagnoses, and in addition to those diagnoses, a way of measuring levels of impairment or functional impairment, and then in addition the third criteria being, and if we provide the appropriate interventions, does the person receiving the services, what is the likelihood that they will benefit from those services? So those are the 3 components of medical necessity criteria in order to access specialty mental health services. Over the years, of course, the general public does not understand that. I think there's been frustration over the years that people will call and ask for services and are told they don't meet the criteria. That's the basis of the criteria. So, on from the medical necessity criteria, under the rehabilitative SPA, the really monumental things that we've been able to accomplish are, 1, it moved us from a clinic model to a community-based model, meaning that it got us out of the confining 4 walls of a clinic so that services could be rendered either in a clinic setting, by phone, in the home, in schools, in the community, increasingly under the freeways, in homeless encampments, really anywhere our beneficiaries might be and where we might go to outreach to them. So that was really very important. Along with that was the development of a very broad continuum of care. Until I'll do an addendum here with the Mental Health Services Act, but prior to that, the range really was from sort of traditional outpatient, individual and group therapy, but then really continue to build from there. So, if you start with lowest level of care, it's outpatient therapy. From there, you think about a variety of different crisis services like crisis stabilization, crisis residential, go on to there to transitional residential, go on to there, from there to long-term subacute block facilities, go from there to acute inpatient hospital, and from there state hospital. So it's a pretty broad continuum of care that we're responsible for managing. Under the Mental Health Services Act, very fortunately, we've been able to add prevention and early intervention to the very front end of that continuum to complete it. There's that. In addition, under the SPA, we've been able to build very diverse treatment teams that would include MDs, PhDs, LCSWs, MFTs, unlicensed mental health specialists, and I think very importantly, peer providers and family partners, parent partners, in building a really robust system and being able to provide the correct service at the right time in different types of communities and settings. I think also, I would say under rehabilitative services, the quote here is rehabilitative services, as we know, include assessment, treatment planning, individual and group therapy, medication services, all those other things we talk about. But the official quote is recovery and resiliency-oriented services that restore, improve, or preserve the person's functional, social, community, and daily living skills to support self-sufficiency and self-regulation. That is what specialty mental health services is, and it's quite distinguished from those services that are provided for mild to moderate, as listed previously. I would say, in closing really quickly, that for specialty mental health services under the mental health plans, funding has become increasingly graded, so that there is Medi-Cal, there's state realignment, there very significantly the Mental Health Services Act. In addition, there are state and federal grants, and then in addition, there are county funds contributed. So it's very graded funding, and what we've seen in the last couple of years with realignment for law enforcement is increasingly 109 funding being graded in with all of these others that I just mentioned. And then I think I should probably end here, right? So the last is we're also very graded in terms of who we're interacting with and providing services with. So we really are part and parcel of the safety net fabric in any county. We work very closely with the Departments of Social Services and Probation, work closely with the courts, with law enforcement, the schools, etc. So it's a very interwoven system that's developed with specialty mental health services as managed by the mental health plans, part of that safety net.
Thank you, Suzanne. Very good. Jody.
Hi, thank you for hosting us. I am very pleased to represent the federally qualified health centers and community clinics throughout the state of California. There are approximately a little bit over about 1,000 of us at this time in the state of California, and just to give you sort of an overview, I'll try very hard not to get in the weeds of this. In 2012, our IPHI data reflected that we provided over 600,000 mental health visits in the community clinic world alone. And traditionally, we are not part of the public discourse when it comes to the provision, the services that we provide in a very holistic way for folks who sort of fall in the lower socioeconomic rung in our state. So this is a real treat for me to be here to represent the community clinics. So we just actually, I'm part of the California Primary Care Association. I sit on the chair of the Behavioral Health Peer Network. So we just recently compiled our 2014 data on sort of where folks are at in terms of integrating behavioral health care, and how are we ramping up and implementing, ACA in order to meet our patients' needs. And it was really interesting to learn that 78% of our clinics already, to some degree, have full integration into our primary care clinics, behavioral health integration, which is really astounding given what we've had to do to grade our funding streams. I won't get too granular in our funding and our billing and reimbursement mechanisms, but you mentioned sort of the language that needs to happen between all the different systems that are now interacting together, and the federally qualified health world has its own very unique billings and reimbursement system. And so communicating that and translating that to many of our partners in this has been one of the opportunities that's been presented as an advent of the ACA. So I would care, given that we're in Sacramento, we're in the geographic managed care world, we're one of the lucky 2 counties in the state, and I would characterize our relationship with the health plans right now as we're in the courtship phase. We're laying out what you need, what we need, what our patients need, and really trying to mix those boundaries and figure out who can do what and how can we best serve our patient population that is coming in. And the federally qualified health centers and the community clinics are traditionally we're based in the natural settings of our patient population, and so we have a very unique challenge ahead of us in terms of ensuring that we are addressing the health disparities of the folks that we are serving. And we're managing to do that in a couple of different ways. And primarily for us, one of the main ways is the co-location of services, is ensuring that there isn't a wrong door when someone comes into one of our clinics, whether they screen positive during a primary health screen and we have a behavioral health consultant there right on site to provide the service, or whether or not we are out in the community and providing a service and can bring the services directly to folks' natural settings. So I think that's one of the really unique advantages of being affiliated with the community health clinic. So that co-location is something that all of our clinics throughout the state are striving to make sure that we accomplish. And it goes on to several levels, but also reducing stigma for folks who may be more comfortable disclosing something in a primary care setting than identifying as a mental health patient or a behavioral health patient. So that's one of the areas that we're working towards. And then I mentioned sort of the addressing the health disparities. MHSA has, you had mentioned, Dr. the PEI funds. Over half of our participating clinics have been able to avail ourselves of MHSA PEI funding, which I can't even highlight enough what that has allowed community clinics to be able to do in terms of participating in the workforce development, the training, the recovery-oriented practices that MHSA touts, but it also provides community clinics an opportunity to bring on some non-traditional providers or historically unreimbursable providers under our FQ umbrella. So that would be the indigenous healers, community health workers, peer advocates, alcohol and drug counselors, promotorists. It has afforded our clinics opportunities to really take our services out into the communities and meet the unserved need. And just to give you an example, in Yolo County, the MHSA PI funding supports a targeted medical and behavioral health outreach program to the Latina population and Latino population in that county, which was identified as part of a stakeholder needs process. In other counties, we have medical and behavioral health clinicians embedded within senior citizen homes, as an example. And here in Sacramento, WellSpace receives PEI funding in order to support a Social Security project to help expedite disability enrollment benefits for folks experiencing homelessness. We also receive PEI funding to promote the PHQ-9 depression screening with all of our patients and provide subsequent follow-up at a behavioral health level. So that is just a very, very small snapshot of where we're at. I could be here all day trying to sort of lay out the behavioral health cartography of California because it is implemented very differently across the 58 counties. And because sort of that bifurcation that we've talked about and has been talked about here between our SMI population and our mild to moderate, that is probably one of the more significant challenges we face on a daily basis because we really truly believe that anyone that comes in, we have a mandate to serve under our FQ umbrella, and teasing out sort of a diagnostic versus a service need and where someone would fall in that and navigating our county mental health plan and as well as the 4 health plans that we contract with and still ensuring that our patient is getting an experience that we would want to relive if that were us in that setting. And it's very difficult to ensure that when we have this sort of tiered system. And so, on the reverse, if we have somebody that enters in as in the mild to moderate category and may destabilize, it's very hard to rectify in our world that we would have to transfer them out to another system. If somebody who experiences diabetes, they're not in a tiered system and get sent to it somewhere else for care if things escalate. So that's sort of how we look at it, and really trying to reach an environment or an atmosphere where we can serve our patients regardless of what their level of stability is at, and making really seamless connections and collaborations with our county mental health partners. And different or different counties that's operationalized very differently. And the MOUs are working seamlessly in some counties, and others it really depends. And as well as access to that MHSA PEI funding. I mean, that's at the county's discretion. And I think the more that the opportunities can be open to include other community clinics, other FQs to sit at the table and participate in accessing that funding, we're all going to benefit in terms of reaching out in ways that will address the health disparities of our patients that we see in the community clinic setting.
Thank you, Jody. You really laid out many of the challenges we're all facing. Thank you. Brianna.
Great. Good afternoon, everyone. Last but not least, so my name is Brianna Duffy, and I am the Senior Vice President of Client Partnerships for Beacon Health, or Beacon Health Options. We have a slightly new name, so I need to get used to it myself. We serve as a behavioral health vendor to several health plan organizations in California. So as I've been listening to my colleagues, it feels important to me to sort of make a disclaimer about nomenclature, and that is I'm going to define how I'm going to use terms because I'm afraid that they will roll off my tongue in ways that are habit that may be a bit different from the ways that even some of the folks have spoken previously. I serve as really, I think, the health plan, meaning the new health plans that are being asked, not the county health plan entities, that are being asked to help implement what we think is an excellent option for members that we're serving, and that is the mild to moderate mental health benefit. We often refer to the county entities as the county, so I will talk about counties in that way. The one thing that was really clear to me as I was listening to my colleagues talk is that while the approaches and the different views that we all bring to the conversation vary, there's really a neutralizing entity, and that is to help serve the individuals that are receiving Medi-Cal benefits when they need access to mental health services. And so that's a little bit about who we are and what we're doing. So as the behavioral health vendor to some of the health plans that we're working with in California, we have the great opportunity to actually deploy what we refer to as both centralized and localized resources. When I talk a bit about the localized resources, Beacon deploys a model that we call our integrated partner model. So for many of the same reasons that you've heard folks talk about, we do this so that we can enhance the integration of care that's afforded to the members that are served. And that is both across the medical teams, disease management teams, pharmacy teams within the walls of the health plan, so that we really can afford ourselves the ability to look at folks from more of a holistic view. The other thing that I would say is because we are partnered with multiple health plans, we talked about the variance at times between the different county organizations. A bit of background about myself is I actually come from Massachusetts, and we used to say in my life of the world in Massachusetts, when I would talk about the ways in which different Medicaid programs worked in other states. If you've seen one Medicaid program, you've seen one Medicaid program. Little did I know, when you come to California, you've seen one Medicaid program, you've seen 58 Medicaid programs. So just when you thought it couldn't get any better, it does. It's exciting though. I mean, I think really the common thread is about serving members and how we can collectively do that. So we're excited with the charge, we're excited with the experience. And that is a bit what I'm going to talk about in the past year, is that we look at the infusion of the benefit of an experience and a process. And I note that because I think when we're talking about process and systems change, things don't happen overnight. And while we've seen some tremendous progress, and we can resoundingly say that we think success has been achieved at the member level, thinking about the rubric of the triple aim, that we're really able to bring new services to folks that have not had this available to them in the past. We're still in a process that will continue to evolve developmentally. And so a little bit about this afternoon's comments from me on behalf of Beacon and the health plans that we're working with, we'll talk about the process that we've deployed in the past year and what we intend to do a bit more in the future. So we have, in fact, seen members have the ability to access care. So we feel like that's check one. We've done some good things. We've been able to help make those needs a reality. When we talk about the mild to moderate benefit, we obviously feel as though there's also the need for folks to have access to care that extends beyond that. And of course, we need to have good working relationships with the counties that we're also working in. And so to that end, we've sat down, and as I think Sarah talked about as we got going today, we got to the table, we talked about what services looked like in the county, we talked about how we would work together, and we ultimately formed memorandums of understanding. And again, when I say we, this includes the health plans, obviously, as the folks charged with doing this. From our perspective, it really afforded the ability to have a no wrong door. And so when folks need service, they don't often know what services they need. They just know that they have a service, that they have a need that needs some type of service and help and support. And so whether or not the individual has first touched the county system, whether or not they first touched a primary care practitioner, whether or not they've called the health plan directly to say, hey, I think this is what's going on, I need some help, we have the ability to sort of serve as that traffic cop and help kind of navigate the system and get folks connected with the right places at the right time. And that feels equally important. And really within the walls of the health plans, we've been able to achieve greater holistic care. Talked a little bit about the integration with case management. Health plans have had case management for a number of years. Whether or not they've had the depth of behavioral health case management has varied. So Beacon case managers and our licensed clinical social workers are sitting in the walls of the health plans. We also have what we refer to as sort of our own health navigators, and the definition of a health navigator depends a little bit on the health plan relationship. At times that may be someone who's worked in the county system in the past and is extremely knowledgeable about the resources that exist. At times it may be someone with lived experience, and so how that comes out is really a bit varied. Again, in talking about the fact that this is a process, those are the good things that have happened in this past year. We continue to think that as we move into the next couple of years that we will continue to perfect this. It was a little bit of music to my ears as Sarah was talking about the integration of some of the data, and that was actually on a wish list for ours. And so to the extent that we can look at sort of combined data in a more meaningful way, it might help to do some of that direction of members without needing to go through the process of having that administrative directive process occur that happens to, I didn't say that well, but hopefully you get the gist. So again, we do have the MOUs in place with the various county entities that we're working with. We do have the good fortune to work with several different counties, and what I would say is that there really are nuances and differences. I think that as much as we have systems and protocols, the human element comes into play. Who's in different positions, relationships, and those personalities often can make a difference as well. But by and large, we've had a resounding willingness to come to the table. Anytime there's a member need, we can talk about what makes the most sense, and that has worked really well. We've also put a fair amount of effort into the education and training of primary care practitioners, helping for the primary care docs, their clinicians, folks in the office to understand that there's a new benefit and helping to get that message out, and really also helping to serve as a one-stop shop so that if they're not sure sort of what to do for a referral process given this new benefit, and if it's a little bit confusing, resoundingly what we've kind of said is just call us and we'll be happy to try to make that process work. We've also rolled out what we're referring to as our primary care toolkit, and that really talks a lot about the different screening tools that are out there. I think, Chris, you mentioned earlier, our pediatricians have been very good about screening for a number of years. Our adult practitioners are getting better with it, but at times they're wondering if there are different screening tools that could be helpful. And so we've put together a toolkit that we hope will also help in that process. A little bit about our provider networks. That was one of the things that we definitely wanted to make sure that we could touch on today. I can speak for Beacon and our health plan partners to say that we have largely expanded our networks. The number of practitioners that are within our provider groups have grown exponentially in the past year. With that being said, we also know that in some places in California, we've got more challenges than others. And so some of that has to do with the general workforce, whether or not there are practitioners available, whether or not there are practitioners who are interested in being reimbursed by Medi-Cal. whether or not there are, just the geographies in play and the distance that needs to be considered in making those connections. So this remains an area of priority for us. We continue to actively work to recruit additional qualified providers to the network whenever we can. We too are looking at the leveraging of telepsychiatry and other mobile technologies as care extensions, and we'll continue to take this on. So as I talked a little bit about the process, what's happened in the first year and what we anticipate we will do in the future year and years to come, that's a little bit about what we anticipate you will see. Again, we are incredibly happy to be working with the different county entities. When it comes to chemical dependency, we know that there are also new players that we're getting to know and helping to integrate with. And it's complex, there's no doubt about it. Hopefully, the more familiar we all get with the way things are working, it will become a little bit more old hat. Again, having been from Massachusetts, I will say, we have maybe a Target shopping store every maybe 15 or 20 miles. So you could use Target as a landmark and you can say, oh, it's near the Target. What I've learned here in California is that is not a helpful landmark at all. So much like, or Starbucks, right? And they're not good indicators of where we're going. Again, in time, I think we will learn to talk in different ways and we will use new landmarks and new indicators, but we will help to change the system and we will help to make this a bit easier for folks to navigate. I guess really in summary, I will just say, looking forward to the next version, the next iteration. Think that in the next year we will see even bigger and better things. And thanks.
Thank you so much. That was very helpful. And you are hearing 4 examples. You are not hearing of the complexity across the state. I think Suzanne Pavana made that point and Brianna made that point, and I think it's important to remember that because we do have 58 different county mental health systems, and we've got, I don't even know how many health plans. 22. And how many QHCs was it?
Between community clinics and FQ is over 1,000.
Over 1,000, all right. So you can see the complexity of this state. I do want to point out a couple of things. You were mentioning the difficulty of finding practitioners. We did an estimate looking at how many additional mental health practitioners do we need in the state of California to address this large expansion that's going on. And the number we came up with was a little over 10,000 full-time equivalents. So we've got a ways to go to really develop our networks as carefully as we need to and with enough practitioners. That is a challenge for everyone. Yeah. So one last thing, and then I'm going to read a couple of questions that have come up. I think it's important to point out, and I do this in a lot of meetings, so if you've heard me say this 10 times before, I just apologize. But I think it's important to remember that people with serious mental health conditions die 25 years before the rest of the population, which is really significant. And the large amount of that early death is not from their mental health condition, it's from their health conditions that don't get treated. So we've been really active for probably 6 or 7 years now trying to work on how do we get health care and all of these new developments through our Medicaid waiver that the state has worked on is really helping to promote that. The other thing I would add is Washington State added, so if you add substance use disorders to the mental health condition, what happens? Well, now it's 30 years that people die earlier. And after all this data came out, one county in Southern California, a pretty large county, not the largest, did an assessment to did some research to figure out what was the average age of death for the people they were working with, their target population. And they found out that it was 41.8 years of age, which was pretty scary for them. And they have really been on a mission to find health care for their folks and developing some of the best integrated care, I think, around the state. So now I'm going to have to put my glasses on to try to read some of these. If people print it, maybe I could read it. So I think this question is for you, Sarah. Is the data skewed by the expansion of ABT in the Medi-Cal and the need for beneficiaries to get their DD screening? I'm assuming that means all screenings. Is your data for the 0 to 20 broken out for teens only?
So I want to clarify the question, can I?
Sure.
So I think maybe this ABT is in relationship to BHT and ADA, is that right? Whoever asked the question? Maybe Okay, I'm gonna go with that. Okay, so last July, the federal government did issue some guidance that said that states need to cover what's called behavioral health therapy as a component of the EPSDT program. And so in September, we did issue an all-plan letter to our managed care plans, essentially stating that they were responsible for the provision of these services. So anybody September 15th, 2014 on is with the managed care plan if they have a diagnosis of autism spectrum disorder or ASD. If they're receiving services prior to that date from the regional center, they're currently still receiving services from the regional center. So I think if this question is tied to that piece, because I think DD is tied to developmental disability potentially, I don't believe that the data is necessarily screened because it didn't start until September, so it's likely not showing up in the data to that significant level. And we didn't present this data, but yeah, I have it broken out by 0 through actually 100, which is interesting. But I do have data broken out by age, so I can look at teens only, yes.
Okay, great, thank you. And the next question, is there any data collected on referrals to substance abuse entities? Where is DHCS on requiring MOUs on substance use services as they've done with mental health?
Okay.
That's a complicated question.
Yeah, so that's a good question. We don't currently collect information on substance abuse service referrals. I do think that's something we'll likely do in the future, especially many of you are probably aware that California is currently working with the federal government on the new drug Medi-Cal waiver, which will significantly change the way that substance use services are provided in California and really kind of change the infrastructure. So today we don't have it, but I do expect that in the future we'll start gathering that information. And then in terms of requiring MOUs for substance use, you know, some of our plans do have those in place because the county addresses both. It's behavioral health, right? So it's mental and substance use services, mental health and substance use services. So I think that as we get more infrastructure in place under the drug Medi-Cal waiver, then we'll start exploring this again. But we are actually having discussions internally in the department so that we can prepare for that and have that ready to go.
Thank you. So I think this is, go ahead, Suzanne.
That was a great question and a really important one. And I think, I'm just speaking personally here, I think historically the benefits, the drug and alcohol benefits available to Medi-Cal beneficiaries have been so limited and restricted that there's sort of a learned hopelessness about this. And so I think people have to be trained, retrained to diagnose and refer, because the learned helplessness has been, why do this if there's nothing to provide? So I think we have to get past that, and the way to get past that is the counties are all ready and waiting, hoping that the waiver is approved for drug Medi-Cal, and then also in partnering with the state that we're able to get more programs certified for drug Medi-Cal services more rapidly, because we want to expand the capacity, but we're kind of held up. We're all partners. But I think once we can actually build the system and have the program certified, there'll be more referrals and more integration, because when you look at bending the cost curve for physical health, it's more on the appropriate provision of substance use services rather than mental health services.
Sure, please.
So that's addiction treatment services is an area where we're very excited about in San Mateo County. Just as a bit of a detail, we pulled some data at a request of our health system just to find out who are these folks who are visiting our emergency rooms greater than 10 times in a given year. So already a pretty high utilization baseline. And we just looked at the top diagnoses. Alcohol use was one of the top 5. Behavioral health conditions was one of the top 5. And so with that, we wanted to get ahead of that and starting to identify and refer. And the nice thing, again, our county behavioral health system has that infrastructure to do the referrals. The learned helplessness came actually in the medication-assisted treatment side of things, where our providers never really had to do anything about it or never knew. Gladly, starting a couple years ago, we started training both our psychiatrists and our primary care providers about the medication treatments and promoting it. And so we're robustly promoting that more, and we're starting to see more of those prescriptions happening. We actually have a pilot using the long-acting injectable naltrexone as well, and seeing really good results because of that. Yet there's a lot of work because it never was covered. All of this is workarounds, but we know because we just want to make sure these people get treatment. Otherwise, we know what will happen. It will not be pretty.
I think that's pretty common across the state. Some places more than others. I mean, San Mateo's had a very robust substance use services for quite some time, more so than most areas. But as I understand it, this new drug Medi-Cal waiver, assuming it's approved somewhere the way it's been written, will really develop a continuum of care in all of our state. Some places it's already somewhat developed, other places it's not developed at all. So that will have to happen over time. And the way the waiver is written, there is a phased in, so it's going to be region by region to try to develop these new services. And the first area is going to be the Bay Area, which happens to have the most developed substance use services. Some other places are pretty well up there too, and other places it's just not existing at all. But I think it's important also to realize that in most places, substance use services are provided. They may not call it substance use when they do their billing, but it is taking place to some degree. So it's going to be another challenge, another big challenge to implement this new continuum of care. But I will tell you the rumor's already out because I'm getting calls from other states already saying, what are you guys doing now? Wanting to hear more about this development of this continuum of care because it doesn't exist anywhere in the state. So now, Terry, this is a question for you. I thought FQHCs have to provide both physical and mental health services. You spoke about something. With any clue what that word is? Okay, about coordinating with the managed care plans. Is the FQHC providing the mental health services for the plans in Sacramento?
Great question, and yes, we are providing primary and behavioral health care. It's actually part of our model, and one of our requirements is that folks that are members of our clinic are assigned to us, are seen by a primary care physician. They get a physical. We're going to rule out any organic physical health issues because I sure as heck don't want to refer somebody to our behavioral health department and issue a psychotropic medication for something that may be occurring due to a thyroid issue or something else. So we believe that we want to, make sure that our members receive access to both. Yes, in terms though, the nuance as a result of the ACA has been traditionally, we receive two payments, a state and a health plan and a state. It's called a RAP or PPS rate. The gatekeepers now essentially are the health plans. So that's a different relationship that we've had in billing and reimbursement before. So on the behavioral health side, we have to get an authorization, and our initial payment or reimbursement is bill is sent to them, and then we get the RAP payment from the state afterwards. That's maybe too much in the weeds for some folks, but that's sort of how it works, and that's a nuance that we haven't had to work through in the past before. But it's one that's obviously very well worthwhile because we are known as a safety net, and many of our members have never been insured before. So it's wonderful that they're coming in with insurance, and which obviously assists our clinic operations as well too, and provides an opportunity for us to be able to enhance our services. So the more Medi-Cal beneficiaries that we receive, I am able to craft other sort of ancillary or enabling services as a result of that. So care coordinators, which are not currently a billable provider under our system. If I have enough Medi-Cal revenue, then I can add these other services in. I can add outreach services. I can add portable, psychiatry or primary care services, and get folks out into the community more as a result of that. So it's definitely a nuance for us having to sort of go through that extra level of billing process for us with the health plan. But it's actually been quite smooth. I mean, everybody has just sort of rolled up their sleeves and just figured out a way to make it work. And I've had the privilege of working with Beacon in Yolo County and now here in Sacramento County. And everyone seems very, very committed to that patient experience and to sort of learning the language of one another around this. So.
We do several learning collaboratives around integrated care, and the team has to be mental health, substance use, and primary care. And I'm always amazed that when you get practitioners in the room together, they're going to figure out a way to make it work. And stay legal, but they're going to make it work.
A little skewed on this.
So here's another question. And I think this is for you, Sarah, does FQAC data show up in the Medi-Cal encounter data? If not, how do we get a whole picture?
Okay, great question. So yes is the answer. So any encounter that would happen at an FQHC, for example, at one of Jody's FQHCs, would be reported by the FQHC to the health plan and then reported to the department. So it does show up in our managed care data. I think another alternate place, and Jody may speak more to this, to look is to the OSHPD data that she talked about, because there is clinic data reported on the OSHPD website that does break out individual information by clinic.
Okay, the next question, and this is for anyone who wants to answer it. Why are so few older adults accessing care?
I would like to start a stab at that. You know, what we're finding is in the older adult population, particularly at the older adult Medi-Cal population, but then you also start talking about the Medicare population, because older adults tend to have Medicare. But there is a large trend that we're seeing that older adults really do not want to go in somewhere to get service. So it's really a matter of reaching out to them into the homes, and it's really outreach and engagement and providing the services in that setting. My guess is, and Chris is looking within the primary care setting where people are coming in for their physical health, it might be that the prevalence is greater there.
Right. For us, what we've uncovered is there are two parts to it. One ends up actually requiring more evaluation. There is the access and preference in terms of the relationship with the primary care provider or geriatrician, of which there are, we have some programs that actually specifically cater to that population. One of the things, though, as Suzanne pointed out, as we get older, we're getting into the Medicare population, and Medi-Cal, Medicare data do not necessarily mix. And I'll tell a quick story before. San Mateo is a duals demonstration county. And so we're trying to integrate all of the Medicare, Medi-Cal data and to really see a holistic picture of somebody. Before we did that, we identified someone who had 100 emergency room visits. We did not see that at all in the Medi-Cal billing because they had Medicare. And it was only until they came in that we saw that data that we thought, oh, we really need to reach out to this person. We didn't even know this. And so in that integration of information is only where you can actually begin to start delving deeper and trying to figure out what's going on. And so on the Medicare side, we're starting to see more and more of that. Of course, now we're helping our behavioral health folks also learn the language of Medicare and being able to capture that information more adequately. So there's a lot of work there. It's rich in terms of actually integrating that data, but it's still very, very new.
The next question, and maybe this is yours, Sarah, but anyone could try to stab at it. How do these percentages compare to previous encounter data?
So I think what I would say is that mental health was not a requirement of the managed care plans prior to January 1, and so we wouldn't have seen this in the encounter data.
Okay. And what measures are being taken to secure access information for people with mild to moderate conditions?
So timely access to care. I think the question is about timely access to care. So the department engages in a number of ways to monitor our health plans. There are a couple of kind of big picture things that we do. Department of Managed Health Care triannually goes in and audits health plans, and that has a specific focus on mental health. We also have our audits and investigations division at Department of Healthcare Services that is now doing an annual audit of our health plans, and we're adding the mental health component to that audit. Separately, we review a lot of different data that we call indicator data. So that's that grievances and appeals data that I talked about. We pull some different metrics of information that we look at, that quarterly data that's reported to us. How many calls are coming into our Medi-Cal ombudsman where a beneficiary is complaining about not getting access to care for mental health services? So we collect that data. We also work really closely in partnership with DMHC, with our mental health division at DHCS, and are having regular meetings to talk about where are we hearing that there are timely access issues, and frequently we talk about that. So we look at a lot of different kind of data sources, and I think to Brianna's point, there are some areas in California, just to be upfront, where there are provider shortages across California. Okay, let's just be upfront about that. Especially, in many different areas, but psychiatry is one area in particular. And so, there are some areas that are more challenging, and so, that's where it comes back to some of the things like telehealth and other things that we can try and do to think outside of the box in terms of providing timely access. And, the department, Sandra and I were yesterday at the stakeholder committee meeting for the waiver. One of the things that the department is looking at in the new Section 1115 Medicaid waiver is tied to workforce development and tied to that co-location that Jody was talking about. And so really kind of thinking about how do we think outside of the box to grow that access to care.
And I'm so glad this came up, and I could add to that in terms of workforce development, I think, for all of us. The Medi-Cal population is a very diverse population, and in order to provide timely access and appropriate services, we really need to, I think, continue to build our workforce in terms of linguistic capacity and also cultural capacity, because it's not always that there are differences just in language. If we don't understand the culture and are not culturally appropriate in what we're doing, it's very hard to serve underserved communities. So I would just add that to the workforce development conversation.
Major issue for California, definitely. So this is an interesting question, and I think anyone can tackle it that's interested. This is around veterans and talking about veterans experiencing PTSD, traumatic brain injury, a whole range of things, and that many of the folks are either not eligible for VA services or they haven't signed up for VA services yet. And this note mentions that a veteran with PTSD was recently diagnosed with migraines, did not get help, and committed suicide this week. And we're seeing, I saw the number of how many suicides it is across the country recently, and I can't remember the number. I just remember
22 a day.
Pardon me?
22 a day.
Thank you. 22 a day, which is a stunning number. So anyone want to tackle? The question is, are we training our clinicians to understand the kind of military culture and how to work with veterans? So that's a question. I don't know if anyone, I know we did some training a couple of years ago, and I'm thinking to myself, boy, it's time to do this again because it's been a few years since we did that. But yeah.
So I could speak to some broader initiatives in our county. I think starting a couple years ago, we implemented and deployed trauma-informed care and services. And while yes, it's broad, there definitely was a veterans component to it. Understanding that we do see a population of veterans who may not get benefits from our local VA, yet we know to route them to our health coverage unit and find the appropriate county-based or Medi-Cal coverage that they would be eligible for and just get them into services. And from our perspective, it's get them in, get the treatment, we'll worry about the money later. And so I think our system has really evolved with the trauma-informed work, and I think they're moving along. The current focus actually these days is specific to kids, but there definitely was work on veterans.
Thank you.
Yeah. Just to add to that, I feel like I'm just now learning more about what's actually available to veterans, and I think that we probably all should have a primer on what the current status is, because things have shifted a bit, and I think there's actually now more available than has been historically. And I'm learning that from our county Veterans Affairs coordinator, who we're working with closely. He's managed to arrange for psychologists from the VA to come to our site 3 times a week to see vets there. And then under the Mental Health Services Act, we added funding so that he could add counselors to also outreach to the veterans. So I think this is a whole area that you'll hear a lot of different stories and scenarios from around the state, and it's worth sort of collecting them and understanding the kind of landscape at this time.
Thank you so much, and we're about out of time, so I think we need to, anybody have any last minute comments you want to make?
Thank you.
Thank you.
So we'll be around for a few minutes afterwards if you have any other questions you didn't get a chance to So thank you so much, everybody. Thank you, the panelists, and thank you, Sarah.
Thank you so much for being on. If you want to know, our next California Policy Forum will be March 26th. We'll be receiving an invitation to that, but if you want to sit it in our calendar, please do so. Give it a yellow evaluation form, and we would love to have 30 more minutes to talk to our panelists. If you have a question and you're not answers, please write it down, and we'll try to address it through communications following one of that. Thank you very much.
Send them to behavioral health. So it's about your physical health conditions as well. There are free training modules that are free to use.
Sarah, I wanted to introduce myself.